Bismillah ar-Rahman ar-Rahim. Today we will speak about an important subject which is heart disease with pregnancy. Regarding the incidence, heart disease with pregnancy complicates about 1% of all pregnancies. Rheumatic heart disease represents the most common one, accounting for about 90% of all cases, and mitral stenosis is present in the majority of such cases. Congenital heart is the next common, and others like hypertensive and coronary heart disease are the least common. All of us know that there are certain physiological changes occurring during pregnancy in the cardiovascular system, including increase in the heart rate, increase the venous return, increase the pulse rate, and so on. As long as the heart can compensate for these changes, therefore no decompensation or no heart failure will occur. This is what we call the functional capacity of the heart. The functional capacity of the heart. That's to say, so long as the heart can compensate or accommodate such changes occurring during pregnancy and delivery, no decompensation or no heart failure will occur. However, we have some dangerous time points at which decompensation or disruption of this functional capacity may occur. The first time from 28 up to 32 weeks gestation, when the blood volume and the cardiac output are at a maximum. The second time during the second stage of labor, where heart failure may occur due to maximum stress on the heart by the strong uterine contractions and maternal bearing down. Third time after delivery, where failure may occur due to overdistension of the circulation by the blood in the placental sinuses ejected after retraction of the transmusculature into the systemic circulation. And lastly, in the periperium, where the risk of subacute bacterial endocarditis may occur. So, these physiological changes may induce some sort of symptoms and signs reflecting a normal cardiac condition. It does not mean that there is a pathologic heart lesion in the heart. These symptoms include dyspnea, mild orthopnea, easy fatigability, some sort of dizziness, especially orthostatic dizziness. As signs, you may find bilateral dependent edema lower limbs, neck vein distension in the supine position, functional systolic murmur, or third sound may be heard during auscultation of the heart sounds. These symptoms and signs reflect a physiologic changes occurring in the cardiovascular system does not mean that there is an actual pathologic disease. So, how we can differentiate between a pathologic heart lesion and a physiologic symptoms and signs associated with normal conditions associated with the heart. As a diagnosis, you know, from the history, clinical examination, and investigations. From the history, easily you can get a positive history of rheumatic fever since childhood. Second, you may get an information from a congenital heart lesion at the current conditions. You may get also a history of previous cardiac surgery. And finally, you have to ask about a previous history of heart failure, especially occurring during pregnancy. So, from the history, easily you can catch up or pick up the actual diagnosis of the condition. As symptoms reflecting an actual pathologic disease during pregnancy, you may find severe or progressive dyspnea, progressive orthopnea, paroxysmal nocturnal dyspnea, hemoptysis, chest pain, or syncopal attack with exertion. These symptoms reflect an actual pathologic disease associated with pregnancy. As signs, you may find cyanosis, clubbing of fingers, persistent neck vein distension, not supine, just supine and standing, cardiomegaly, sustained arrhythmia, loud systolic murmur, any diastolic murmur, or signs of pulmonary hypertension like persistent splitted second sound. These signs reflect an actual pathologic disease associated with pregnancy. For investigations, you may order for ECG, and we have to know that this is valuable only in cases with arrhythmia, because cardiovascular changes occurring physiologically during pregnancy may induce some sort of ECG changes which are not clinically valuable. So, to diagnose an actual disease of heart disease during pregnancy, ECG is ordered only for cases associated with arrhythmia. Echocardiography, and this is the most important and the most safest one. You can repeat it at any time. Left heart catheterization and technician labeled albumin or red cells, and these both investigations are invasive and ordered only by the cardiothoracic surgeon just before doing surgery during pregnancy. There is a great association called New York Heart Association. This association put a very important functional classification for any heart disease associated with pregnancy. And this classification is an important clinical one and reflects the prognosis of your case. It consists of 4 classes. Class 1, it means uncompromised heart. That's to say, clinically, no discomfort on ordinary activity. Class 2, it means slightly compromised heart, meaning clinically that there is some discomfort on ordinary activity. Class 3 means moderately compromised heart, and this clinically reflected by discomfort on less than ordinary activity. And lastly, class 4, which means severely compromised heart, and clinically the patient is decompensated or in actual heart failure. Any physical activity causes acute distress. So what are the effects of pregnancy on maternal cardiac disease, or the complications may be encountered? First, heart failure, around 28 to 32 weeks gestation, at which the maximum cardiac output occur during the second stage of labor and after placental delivery. The second complication or effect may be peripheral infections and subacute bacterial endocarditis, atrial fibrillation or AF, and lastly, reactivation of rheumatic condition. Subsequently, the effects of heart disease on pregnancy may include occurrence of abortion, increased risk of intrauterine fetal death or preterm labor, and intrauterine growth restriction or growth retardation. These effects are encountered or caused by some sort of placental insufficiency occurring during any cardiac disease associated with pregnancy. And lastly, the incidence or the risk of congenital heart disease on such babies are, of course, more than those with normal pregnancy. So, what is the management? We will discuss this issue under the following subheadings. What are the contraindications to pregnancy? What are the general principles of management of such cases? What about the preconceptional counseling? What are the indications for termination of pregnancy? What is the role of cardiac surgery? How to manage such cases during delivery or obstetric management? And finally, the management of event of acute heart failure occurring during pregnancy or death. So, what are the contraindications to pregnancy? This include grade 3 or 4 NYHA classification, history of heart failure, especially during previous pregnancies, affection of multiple valves like aortic and mitral valves altogether, atrial flutter or atrial fibrillation. So we have the general principles during management of any heart disease during pregnancy. These principles could be applied for every case. First of all, individualization of therapy, and this is a very important item. Every case must be individualized, managed not like others. Second point, team approach, where a team consisting of cardiologist, obstetrician, and anesthesia personnel must be interpreted or help each other so that your case must be investigated by all of these team. Cardiac work is increased by excessive weight gain, anemia, and infections. So these factors must be avoided, otherwise heart failure will occur. Hypotension must be avoided as it may lead to heart failure, especially in stenotic lesions and septal defects. This is what we call general principles for management of any case of heart disease during pregnancy. Preconceptional counseling. That's to say, any couple recently married, the woman had a heart disease coming to you asking for any informations of counseling about her heart disease before getting a pregnancy. We have to inform her about these important items. First of all, that corrective cardiac surgery can reverse life-threatening conditions. In other words, if any cardiac interventions by surgery could be started before getting conception. Second, women with prosthetic valves must be put in anticoagulants. Warfarin and oral anticoagulants are substituted by heparin as it is teratogenic, especially from 6 to 12 weeks gestation. The third point about preconceptional counseling about maternal mortality. You have to inform your couple about the risk of the maternal mortality, which varies with the functional capacity of the heart or the functional capacity classification at the onset of pregnancy. So what are the indications for termination of pregnancy? First, age above 35 years, history of heart failure in previous pregnancy, grade 3 or 4 NYHA classification, cardiomegaly, multivalvular affection, presence of AF or atrial flutter since early in pregnancy, severely stenotic lesions, especially those with pulmonary hypertension, and lastly, cases with cardiomyopathy. All of these are indications for termination of pregnancy. Don't hesitate to take your decision since early in pregnancy. About the approach, better to be done to terminate pregnancy vaginally and before 12 weeks of gestation, because after that any risk of surgical intervention, risk of anesthesia will add to the risk of the heart disease itself, so that the risk of maternal mortality will be increased. What is the rule of cardiac surgery for a pregnant woman with heart disease with pregnancy? We have to know that it could be done during pregnancy whenever indicated. The cardiothoracic surgeon is the only personnel taking this decision. Second, full anticoagulation is recommended, as we said before, till 36 weeks gestation. Then we stop and arrange for management of delivery, mainly in the form of closed valvotomy. Closed valvotomy is the best. Any open heart surgery usually postponed until after termination of pregnancy. For obstetric management, we will speak about antepartum management, intrapartum management, and postpartum management. Antepartum management, first of all, you have to see your case more frequent than others. Any heart disease with pregnancy, you have to arrange for antepartum observation more frequent than normal pregnancy. You may see your case twice weekly, every other day, every day, as long as the clinician indicate. More rest. More rest is very important for such cases than others with normal heart. Avoid causes of heart failure like anemia, infection, hypertension, arrhythmia, rheumatic activity, and excessive weight gain. Treat heart failure whenever occur, whether left-sided heart failure or right-sided one. And lastly, hospitalization is indicated near term and until time of delivery. However, you can admit your case at any time for hospitalization as the clinical condition indicate. But to decrease the cost, hospitalization near term is more frequently indicated. What about the intrapartum management? You have to know that vaginal delivery is the rule unless there is any obstetric indication. Why? Because intervention by anesthesia during cesarean section will increase the risk of maternal mortality. The risk of anesthesia by itself increase the risk of mortality in addition to the risk of mortality from the actual heart disease during pregnancy. Therefore, the rule is vaginal delivery unless there is an obstetric indication. These points you have to be considered during vaginal delivery. First, give antibiotic prophylaxis. Penicillin to cover gram-positive organisms, plus gentamicin to cover gram-negative organisms. Second, the position of delivery, better to be lateral position or semi-sitting. Lateral position, especially left lateral. Right lateral, okay, or semi-sitting position. Pain relief. Pain relief. You have to decrease the pain to decrease the tachycardia, which may lead to subsequent occurrence of heart failure. The best method is to give epidural anesthesia. Epidural anesthesia is a best option to relieve pain during delivery of any heart disease with pregnancy. Fluid restriction. Keep your case at the dry level. Don't give excessive fluids to avoid pulmonary edema. Give just oral sugary fluids, oral juices, and so on. And don't give excessive fluids intravenous to avoid the risk of heart failure. Oxygen inhalation throughout delivery, first stage, and especially during the second stage. And this is an optional and important one. Shorten the second stage of labor by doing a generous episiotomy and performing either low forceps or outlet ventouse extraction. Avoid bolus dose of oxytocin and ergometry. Oxytocin may induce a sudden vasodilatation and sudden hypotension, and on the other side, ergometrin in a bolus dose may induce severe vasospasm and severe hypertension. Both of them may lead to heart failure. As we said before, regional anesthesia is the preferred one, like epidural anesthesia or infiltration anesthesia while doing an episiotomy. The indications of cesarean section, as we said before, first of all, obstetric indication. Second, severe stenotic lesions like aortic and mitral stenosis, presence of pulmonary hypertension, occurrence of heart failure after controlling the condition, presence of severe arrhythmia, especially AF, multiple valvular lesions, and lastly, presence of cardiomyopathy. All of these are indications for cesarean section. For postpartum management, care must be continued as heart failure may occur after delivery because of the infection or occurrence of anemia. Don't forget to counsel about contraception, especially those with indications for termination of pregnancy by doing some sort of tubal ligation. And lastly, how to manage an event of acute heart failure occurring during pregnancy or during labor. First of all, we have to admit such cases for ICU, intensive care unit, hospitalization, of course. Second, diuretics, digitalization, fluid restriction, vasodilators, all of these medications and all of these parameters are conducted with personnel of the ICU, not by the obstetrician. Your rule or my rule as an obstetrician is to terminate after controlling the condition by cesarean section. And thank you very much for your attention.